Hello, everyone. Welcome to Chapter 9. We're going to be talking about narcotics today. This is going to be a relatively short lecture, I anticipate. Um, and I highly suggest checking out the other videos that were listed under watch for this week. And then also, if you can look at any of the optional videos, that would be wonderful. Oh, excuse me. So, when we think about the word, or excuse me, when we hear the word narcotic, it is used kind of across the board, and it is used to describe a lot of different drugs, including stimulants, but that's not actually accurate. So, narcotics technically only refer to substances derived from the opium poppy and their synthetic substitutes. So, we're talking about morphine, heroin, oxycodone, oxycontin, hydrocodone, fentanyl, tramadol, carfentanil, dilaudid, codeine, opium, opana, kratom, those types of substances. We are not talking about like what the DEA would call narcotics, which again would include stimulants um, as well as hallucinogens. So, we are talking about opioids and opiates. So, opiates are going to be naturally occurring substances derived from the poppy plant. Um, just to kind of share, I should have put a picture on here. It actually is a beautiful plant um, that we used to, not we, excuse me, that used to be left out in the sun to dry and crack open, and then folks would either scrape out or um, eat or make tea or food out of the opium in the middle. We also are going to be talking about opioids. So these are synthetic substitutes. Okay. In 2014, it was estimated that about 2 million people in the United States had an opioid use disorder related to prescription painkillers. Okay, so we're talking about folks who had been prescribed medications, whether they be morphine, oxycodone, oxycontin, Vicodin, or hydrocodone, fentanyl, and so forth. So we're not talking about heroin here, we're talking about prescription painkillers. 2 million people. I've seen some information from 2018, and that number is closer to 3 million people, which is interesting because overall, doctors have really been forced to crack down on um, the writing of these prescriptions. And part of that is because, well, you could call it a conspiracy if you like, but we were told by the oxycodone, oxycontin manufacturers originally that these substances were non-habit forming and that they were relatively safe. There was actually a commercial, and I'll try to find it and post it for this week, but there was actually a commercial that talked about all the amazing things that opioids helped with, including like playing with your children, having chronic pain and being able to be present with your family again, which is lovely. But it's just really ironic considering what we now know about opiates. Anyway, um, there is important clinical value to these medicines, and that's a conversation to be had around this idea of doctors being unable to prescribe pain medications because some people actually really need them, including people in recovery. So, if you've ever had a substance use, an opioid use disorder, it's really hard, even after um, painful surgeries or painful experiences, to be prescribed these medications because we are people in recovery. So there's a lot of discussion around this and the abuse potential. So again, the most common clinical use of opioid narcotics is to relieve pain. Um, it activates the same group of receptors in the brain that are controlled by what we call endorphins. And so this is one of those substances that causes downregulation. So we talked about that in chapter 4. So when we start taking pain medication or kratom or any kind of opioid or opiate, our body stops making endorphins as well as other neurotransmitters that are responsible. There are natural painkillers, if you will. So when we give our body these things artificially, it stops making them. So if you've ever been on pain management before, you know that when you stop taking the medications, you have pain in places that you didn't even know existed. This is why, and it takes a while for that stabilization or that rebalance to happen. What I want folks to know too is that there is a difference between dependence and addiction. Now, we don't necessarily clarify that in the most recent diagnostic statistical manual, or also known as the DSM. We kind of just have sections of mild, moderate, and severe substance use disorders, which we talked about, I think, in chapter 4 too. However, being dependent upon a medication because it's been prescribed to you for a substantial amount of time is different than being addicted. Now, physiologically, it might not be different. Our body or our brains are addicted, but we do look at that differently in treatment as well as in the medical community. Okay. So activation of opioid receptors, they're also called mu receptors, blocks the transmission of pain, which can also reduce the effects of stress. Okay. So some other pharmacological effects. Morphine is a very potent pain reliever, often used as an analgesic. So to kind of cause a sleepiness, a peacefulness, a calmness. Okay. Tolerance can certainly develop with the use of morphine and all other narcotics. And we, again, have seen under-prescribing for fear of addiction, which is reasonable because we are also in the midst of an opioid epidemic. Okay. So physicians find themselves in this weird spot where they know people need adequate medication for pain management. However, we have to be careful in prescribing. So when we talk about abuse, tolerance, and dependence, I kind of got ahead of myself there when I talked about dependence. So these are considered Schedule 3 drugs. I'm sorry, I don't know why it's not in there. So they do have a high abuse potential and also are frequently used to mitigate pain and in medicinal purposes. Tolerance occurs most rapidly with high doses given in short intervals. And typically we see tolerance occur only after 2 to 3 weeks of frequent use. So it's relatively fast. We also see a tolerance level increase fairly quickly. So something that we found is doses can increase as much as 35 times in order to regain the narcotic effect. So for example, when we first try opiates or heroin or any kind of opioid, we get this euphoric feeling, this high, if you will. It can take up to 35 times that amount to feel the same effect down the road. Okay, so tolerance builds fairly quickly. And frequently we see overdoses due to, let's say that I've quit for a little while. Let's say that I was using a 0.5 gram of heroin before I quit. I have some sobriety, let's say for a couple weeks, and then I do a half gram of heroin because I was so used to doing it before. Frequently, we do see people overdose in that way. Physical dependence invariably accompanies severe tolerance and typically expresses when these drugs are used for more than 2 to 4 weeks. So you can have a pretty substantial withdrawal experience just after a couple weeks. Like I said, it's quick. Um, Psychological dependence can also develop, meaning you may not have physical dependence, but that psychological, that need, that urge will develop. Just a couple statistics. So worldwide, it is said that there's about 13.5 million people taking opioids. About 9 million of those folks are using heroin. Okay. There is, we do see these numbers kind of concentrated throughout the world. There is a video that talks about heroin use in Pakistan, and I think it's something like 8 million people are using opioids there, or addicted to opioids, excuse me. So that video is in your optional resources section for this week. Very interesting. I would check it out. Also, we see folks much younger than the average heroin user here in America. Folks addicted to heroin over there are, it's not uncommon to see an 8, 9, 10-year-old who's addicted to heroin. Approximately 2 million Americans meet criteria for opioid use disorder. So this ranges from heroin to prescription medications. And about 130 Americans die every day from an opioid overdose. So again, we saw a slight decline from 2006 to 2016 opposed to 2017. But our population is also increasing, and we're teetering on that line where we have a lot of older folks in our population, so more people maybe needing opioid prescriptions. So the proportionality isn't, while we are prescribing more prescriptions at this point, per capita it's less, so per person it's less. So about 20 to 30% of people who take prescription opioids misuse them, so don't take them as prescribed or sell them. We might be taking them not all at once, but taking too many at a time or snorting them rather than taking them orally. And about 5% of people with an opioid use disorder, so folks who are using prescription opioids, will eventually try heroin. So some guidelines that are given to avoid prescribed opioid abuse, So if you're prescribed an opiate, these are kind of the guidelines to follow to ensure that you don't become stuck. So only use it when you need it. Try to be as conservative as possible when you take it. Take the minimal amount. Store these medications securely to prevent theft and misuse. Don't share your medications with anybody. Doctors should screen patients for abuse risk before prescribing opioid drugs. So this doesn't necessarily mean, determining whether or not they had a substance use disorder before, but also like, are they at a point in their life where they're experiencing extreme stress and something that they need to escape from, essentially, because that could be a risk factor for abusing opioid drugs. Also, patients need to know what they're getting into. They need to know what they're signing up for and what the potential outcomes could be. So letting folks know all of the information, the full extent of the problem, what could potentially happen, and then You know, I've heard of a lot of folks just getting cut off of pain medication because they've tested positive for marijuana or they were caught abusing it or so forth. I don't necessarily agree with that because I think many people need this medication. And I do think that there's other ways to mitigate abuse, but maybe this is referring to therapy, checking out any underlying issues, taking appropriate steps to stop the abuse. Some of the side effects of opioids, drowsiness, respiratory depression, so slowed or labored breathing, nausea and vomiting, inability to urinate, constricted pupils, constipation. This is a pretty serious issue with opioids, and physical dependence and withdrawal. Okay. And I just want to say that this respiratory depression is the major cause of overdose and death, is because it slows down our breathing and our respiratory system so much um, that we stop breathing. Opioid withdrawal is one of the longest studied and most well described of the withdrawal syndromes. So it has been described as being kind of like the flu. So we could have fatigue, restless leg syndrome, muscle pain, goose pimples or goosebumps, um, as well as having a stuffy nose, um, with being extremely exhausted, unable to sleep, heightened anxiety, depression, um, as well as you might again see some nausea or vomiting. Um, as a person in recovery from opiates, I can tell you that while you're in it, it certainly sucks. It feels like the end of the world, like you're going to die. And it's really hard to not seek relief in that withdrawal space. But generally, um, it's not going to, the symptoms are not going to kill us. People die from heroin and opiate withdrawal sometimes, but it's not as severe as like a CNS depressant withdrawal. So something like withdrawing from benzodiazepines or alcohol. So some of the withdrawal symptoms that we see, so I mentioned a couple of these already. Um, Sweating, inability to sleep, constant yawning. Later symptoms that can come, cramping. Many of us, when we're using, we don't go to the bathroom very regularly. So when we stop using, we start going. So that can cause a lot of pain in the belly. We can also have increased heartbeat and high blood pressure. Okay. So this medication or heroin can be taken orally. Sometimes if it's in a powder form, people will do something called parachuting. So they'll put it in a little piece of tissue or toilet paper and just swallow that. By snorting and smoking. Okay. We can also use opioids intravenously and intramuscularly. So most people are not going to inject in the muscle unless they don't have veins to administer the drug. In injecting intramuscularly, it's a hard word. You don't get typically that euphoric type of feeling that you get intravenously when it goes straight into the bloodstream, straight to the brain. It takes a long time, but you'll see a lot of late stage IV drug users injecting in the muscle because they don't have any way to get it into the vein. Okay. Sometimes opioids are also used rectally. I wouldn't say that that's very common. I think smoking is pretty common as well. So, if you've ever tried opioids, typically it's not great the first time. I remember getting pretty sick and vomiting after, um, finding a couple of my parents' painkillers and sharing them with my friends. Um, but you try it again and you try it again, and then you really um, start to understand what that looks like. But at first, it's very unpleasant. Highly euphoric. Again, physical and psychological dependence can occur with daily use within 2 to 4 weeks. And if the user stops taking the drug after that 2 to 4 week period, you can experience withdrawal symptoms. Uh, Heroin and opiate use will certainly affect an unborn child. It actually creates dependence in the newborn. So, any withdrawal or any dependence that the mother has is going to be passed on to the newborn. And many times we see babies born in withdrawal. Okay. These withdrawal symptoms can cause certainly colic, so emotionality, lots of crying, lots of pain in regard to digestive issues, sweating, dehydration, problems with attachment and latching during feeding, vomiting, nausea, maybe even seizures. Um, so, this withdrawal occurs in newborns of any women who use significant amounts of opiate drugs, and that's whether it's prescribed or illicit. Okay. Um, we also don't want mothers to go in withdrawal while they're pregnant. So frequently, if a mother wants to stop using opiates in pregnancy, they will be given methadone um, and stabilized on methadone throughout their pregnancy. Baby will still go through withdrawal symptoms when they're born, but managing the dosage and planning for that is a harm reduction tactic that we use to keep the baby as safe as possible. um, so opioid overdose can happen with any illicit drug use, especially with heroin. We don't know what's in it. Apparently, there's now fentanyl in heroin, which seems really odd to me because fentanyl is very expensive and hard to get. But um, when we take opioid prescriptions that were prescribed to somebody else, opioids can also be potentiated by things like alcohol and marijuana. So we can see a greater effect of the opioid if we're mixing them. Also, sometimes patients misunderstand the directions for use and they accidentally take an extra dose of medication, or they deliberately misuse it and take too much. Okay. Signs of an opioid overdose, so very low respiratory function. Person is not aroused or awoken when touched or spoken to. Okay. Pinpoint pupils. If they start to turn blue anywhere, this includes in the fingertips, lips, and nose. 911 needs to be called immediately, and potentially CPR needs to be started. If you do work in an agency or have Narcan on you, this would be the time to administer it. If they don't have opioids in their body, it's not going to kill them. So if you're wrong, it's better than them dying. We'll talk more about Narcan in a sec. So heroin, you typically, it's on a scale of pure white powder, which is pure heroin, to black tar. So you can see brown heroin, tan heroin, tar heroin. Most of the world's heroin comes from Afghanistan, but the primary source of how it comes into the US is through Mexico. Okay. So it is produced in Mexico as well as Afghanistan, but most of the heroin that we see here comes up from Mexico. it is much more pure, or it is typically more pure when it crosses the border. But then we have folks cut heroin to make more of a profit, and we see a range between 3% to 70% pure. So these variances in the um, purity can be an issue regarding overdose too, because I could use heroin from one person and have it be pretty light, not really feel a lot, and so I have to do more, and then I do that same amount of the pure heroin, and it results in overdose. Okay. Some of the long-term effects of heroin: insomnia, collapsed veins, um, damaged tissue, and this could be in the nose or in the veins. So you also see folks with abscesses. Okay, so this could be from injecting improperly, using unclean, unsterilized paraphernalia, also continuing to inject in the same spot. We kind of develop scar tissue that can become inflamed. Also, what we frequently see with IV drug use is endocarditis, so an infection of the heart lining, which can be fatal. Lots of constipation and stomach cramping, irregular menstrual cycle, sexual dysfunction. It can also cause symptoms of anxiety, depression. Um, we can get infections in the lung and immuno diseases, if you will, liver and kidney disease. Okay, because it does affect our urine output. So heroin is typically cut, like we talked about before. Sometimes this is with lactose, which is found in baby formula. Um, Also, a chemical called quinine. Um, Also, vitamin B is something that is frequently used to cut heroin. Sometimes even Tylenol. Okay. Um, like I said, allegedly, folks are mixing fentanyl and heroin, which would certainly make it dangerous and highly potent. Um, Sometimes heroin, especially IV heroin users, engage in speedballing, which is a mix of a stimulant along with heroin. So this might be cocaine or meth. Um, but most frequently, heroin is used paired with alcohol. So, what we know about the best practice for opioid use disorder is medication assisted treatment is fairly successful in getting folks into treatment and helping them change their lives around. So, the major um, medications that we use for this is buprenorphine, Suboxone, Subutex. So the difference between Suboxone and Subutex is Suboxone is a mix of buprenorphine, which is a partial agonist. So what that means is it partially fills that opioid receptor in the brain and tricks the brain into thinking that it's receiving opioids. Okay. You might feel a little bit of euphoria or a little bit of a high. Typically, you won't because you're in withdrawal when you first take it. You'll just kind of feel normal, but for the first couple days of taking bupe, you may get a little bit of euphoria, but for the most part, you're not going to get high off this medication. It just barely fills that receptor to tell you not to go into withdrawal, but not to get intoxicated. Okay. So Suboxone also has an opioid blocker in it, known as naloxone. Okay. So it's actually going to, if you were to use opioids on top of the Suboxone, it would be blocked. Okay. And sometimes we see overdose in this because folks want to override that Suboxone Narcan dose, so they take more heroin or more opioids to try to bypass it, and overdose can still happen. In Subutex, there is no naloxone in it. It is just the drug buprenorphine. Typically, we only prescribe this to folks who have some type of allergic reaction or problem with naloxone, and also pregnant women. Methadone is a long-acting opioid agonist, so it completely fills that opioid receptor. Um, it reduces opioid craving and withdrawal, and blunts or blocks the effects of opioid. So the idea of a blocking dose of methadone, which is the want, right, is that it fills the receptor up so much that you can't use any more opioids on top of it because you won't feel it. Again, high risk of overdose. Um, Both of these medications are highly controlled. Methadone, you typically won't ever get on an outpatient basis. It comes from a clinic. Suboxone, there are some private providers, private doctors who prescribe this, but is also frequently prescribed in a clinic setting. So what that looks like is, at least for a while, folks will attend a clinic daily to obtain their dosage of these medications. And over time, as they prove that they're staying sober and have constructive daily activity, they will be given what's called take-home doses, and they'll be able to come to the clinic less. The most recent medication that we're seeing is a Vivitrol shot. Okay, so this is a shot, I think it lasts 30 days. That is a complete antagonist. So what that means is it shuts down the opioid receptor sites, so they can't be accessed. So you could do heroin or opioids on Vivitrol, but you won't feel it. Okay. Also, naloxone or naltrexone, which is what is the active ingredient in the shot, is also used as an injectable and through the nose for overdose. Okay, and if you work in an opioid treatment center, any treatment center, I would hope that they would train you in naloxone and how to administer that. Okay, something that I want to say, in my experience in administering naloxone, it does push people into a state of withdrawal, and they can get angry and violent. They're instantly sick, and some of them extremely sick. And also, naloxone doesn't last very long, and so I could administer Narcan or naloxone, and then the person could still, even without using any additional opioids, fall back into overdose. Okay, so if they used a lot, they might need multiple doses of Narcan or naloxone until EMTs arrive. Okay, we're always going to call 911 if we see an opioid overdose. Call 911 and administer Narcan if you're able. So again, this Narcan is a medication that is designed to rapidly reverse opioid overdose. The effects don't last long, so it's still critical to obtain that medical intervention. There is a video and also I think some additional readings on safe injection sites. So this is a prime example of harm reduction, and there is a lot of conversation around it. But what a safe injection site is a medically supervised facility designed to provide a hygienic, safe environment in which drug users can bring in their paraphernalia or obtain new, clean paraphernalia as well as their substance, use the illicit drugs intravenously, and also have nursing staff available if needed. And we can also at that time offer treatment information about basic health care, have access to medical staff, and some facilities even have counseling. So critics of this kind of say that we're encouraging or enabling drug use and bringing crime to the community. The way I see it is people are going to use drugs regardless. It's either going to be on our streets, in our businesses, in the bathrooms, in our alleyways, or it's going to be in a safe injection site. Um, I would rather see that, but like I understand the other side of it too. Um, I think the main piece that really drives this home for me is that many places where safe injection sites are available, treatment's also available pretty rapidly. Okay, so it's not just the safe injection site piece, it's also access to treatment that needs to be increased in addition to these safe injection sites. So there are currently at least 100 supervised injection sites throughout the world, in Europe, Canada, and Australia. Dr. Gabor Mate, if you read In the Realm of Hungry Ghosts in any of your previous classes, he's wonderful. But he has a good example of safe injection sites up in Canada, like in BC. Research shows that safe injection sites reduce overdose and rates of HIV and Hep C substantially. Also in cities where safe injection sites have been placed, they have seen about on average, a 50% decrease in ambulance calls for overdoses in areas where these sites are accessible. Also, they found that folks are less likely to inject in public or leave paraphernalia in the street. So they see a substantial decline in the paraphernalia left out on the streets. And that is it for this presentation. Thank you for watching. Please check out the optional resources and other videos for this week, and I will see you soon.